All right. Well, it is noon. Um, so I think we can start, and that way we'll have maximal time. Um, it is my great pleasure to introduce Dr. Liz Lawrence. For most of us, she doesn't need an introduction. She has been the face and the spirit of wellness at our institution, and she leads a team of committed clinicians and educators to address the issues that she's going to describe today. Liz and I have been neighbors on the dais of many graduations and white coat ceremonies over the last 10 years. And I'm very grateful that she is talking to us today. Dr. Lawrence is a graduate of Yale College and Stanford Medical School. She received her training in internal medicine at UNM and remained in New Mexico to practice. And prior to coming back to UNM, full-time, she was in private practice as a general internal medicine provider in Santa Fe. Dr. Lawrence's branch of medicine, more like the trunk of medicine, has been especially concerned about the social and economic and political influences or determinants on the practice of medicine. The ABIM, American Board of Internal Medicine, was instrumental in advocating for a new professionalism and for the valuation of well-being in the workplace. And Dr. Lawrence has been really at the forefront as a participant and an observer for what I'll call in sort of shorthand term the well-being and wellness movement within medicine. And so without further delay, please join me in welcoming Dr. Lawrence to the Ethics Grand Rounds. Thank you, Liz.
Thank you, Jonathan, for that nice introduction. Can everyone hear me okay? Okay, I'm talking to you from my clinic office, and if anyone else joins me, I may have to put my mask on, but hopefully they won't. Thank you all for being here today. And please put any questions you have for me in the chat. And Jonathan, if you don't mind moderating the chat, either feel free to interrupt or we'll have time for questions at the end. I'm going to start sharing my screen. And can everyone see that okay? Okay, great. This is a topic that I feel really passionate about. I grew up in New York City. I was trained on the East Coast, and I think of New York City and the East Coast as much more hierarchical than New Mexico. And Stanford was also pretty hierarchical, where I went to medical school. And so when I arrived in New Mexico as an intern, I was really sort of terrified and didn't have an idea about what I was allowed to do in terms of taking care of myself. I started my intern year in the emergency department. At the time, I believe we had 12-hour shifts, although it was a long time ago and my memory may be wrong. And no one said, oh, sometime during the shift, you can take a break for lunch, or, by all means, take a 15-minute rest if you need to. And so I didn't, and I was a lot thinner then, and I lost 25 pounds that first month of residency because I honestly didn't know I was allowed to take a break to eat. And so I really came into residency thinking that any kind of care, self-care, was a selfish luxury. And as Jonathan said, I find myself in the position now of advocating for self-care as an ethical imperative. And so this talk is a transition both of my own personal growth, but also of our culture. And I'll be curious to engage you in a dialogue about that when I'm done. I always like to start my talks with a land acknowledgement and recognize where it is that we are. Founded in 1889, the University of New Mexico sits on the traditional homelands of the Pueblo of Sandia. The original peoples of New Mexico, Pueblo, Navajo, and Apache, since time immemorial, have deep connections to the land and have made significant contributions to the broader community statewide. We honor the land itself and those who remain stewards of this land throughout the generations, and also acknowledge our committed relationship to Indigenous people. We gratefully recognize our history. And with that, and with my introduction, let's go ahead and get started. Our objectives today are to really talk about that transition that I mentioned, the idea that self-care is selfish, and how it's transitioned to become much more widely accepted. And we'll talk about some of the national initiatives currently happening to advance clinician well-being. This is the roadmap we'll follow. We'll start with the historical attitudes and trends, talk about well-being as an ethical imperative, talk about how we're going to change culture or how culture is changing, and questions and conclusions. Traditional clinician culture, as I said, has been self-care is selfish. Now, where did this come from? I don't think anyone ever told me that. I don't think that I ever saw that written down. Certainly it wasn't in my Hippocratic Oath or Oath of Geneva, but I certainly came into training with that idea that I should sacrifice everything for my patients and that their well-being should be put ahead of my well-being. And so I wanted to explore some of the ethical background from where that came from. And certainly, if we think of the practice of medicine being defined as a calling, a commitment to work that is personally meaningful and serves society, the idea of a calling brings us to the idea of I am doing something for the greater good. And with that idea comes the idea of sacrifice. It's the utilitarianism approach. And it says, if I am doing something for the common good, the greatest good might be done if I sacrifice myself to take care of others. And so I think that's one place it comes from. It also comes from our history of defining medicine as a profession. And initially, the effort was made to distinguish medicine as a profession from the merchant guilds. And so it involved a commitment to becoming scientifically and clinically competent, to using our knowledge to help patients and help others, and to preserving medicine as a public trust. And part of this was, and I thought I had the quotation in front of me. Let me just see if I can pull it out. Part of this is sacrificing oneself, again, for the greater good. And the idea of meeting the needs of society. The idea of public trust comes with the quote I was looking for, comes with the idea that physicians should remain knowledgeable and competent while at all times placing the patient's welfare above one's own interests. Related to, but slightly separate from the idea of medicine as a profession and not a guild, is our covenant with society and our promise to take care of others. And this was an article that I found very interesting. It was published in 1985, and it was in the early years of the AIDS epidemic. And there was a discussion around, do physicians have to take care of people with AIDS? It seems kind of shocking now that that was even a discussion. I remember I was working at Mount Sinai at the time in hospital administration, and I remember being part of those discussions. But this article in JAMA argued very strongly for our covenant that we did need to take care of people. And what it says in this article is there are at least 3 things specific to medicine that impose an obligation of effacement of self-interest on the physician and that distinguish medicine from business and most other careers or forms of livelihood. Again, related to the idea of medicine as a profession, but also to our commitment to society. And what this article goes on to say is that the nature of illness itself is one part of that covenant. The sick person is in a uniquely dependent, anxious, vulnerable, and exploitable state. Patients must bear their weakness, compromise their dignity, and reveal intimacies of body and mind. And therefore, we are obligated to treat them when we have the knowledge to do so. Our knowledge is not proprietary. It is acquired through the privilege of medical education, and society certainly bears some of that cost. And then finally is our oath of fidelity to the patient's interests. It's the oath that we take, not the degree, which is our formal entry into the profession. And it's a public promise that the physician understands the gravity of this calling, again, that idea of calling, and promises to be competent and to use that competence in the interests of the sick. Some degree of effacement of self-interest is thus present in every medical oath. And so we see through our medical oath, through our idea of medicine as a profession, and by the idea of medicine as a calling, that there are ethical arguments for putting patients first, ahead of my own needs. There's also a fourth argument, and maybe Jonathan can help here, that I couldn't quite put in ethical terms, but is basically the argument of I did it, so you should too. And I hear this a lot. You know, when I was a resident, we didn't talk about well-being. Dr. Benaham, who's in the audience, was one of my attendings, I think, when I was a second-year resident. And certainly I never thought about putting my own interest ahead of the patient's, never thought about sleep or using the restroom or eating regularly. I was there to take care of patients. And the truth is, I didn't do what our residents do today. And I doubt anyone, unless you've graduated in the last year or two, have done what our residents and trainees do today. And by that, I mean, there's this interesting study, this is just one example, published in 2018, looking at trends in what it is that residents have done, starting in 2003, where the EHR became more widely used, going to 2015, so past the implementation of duty hours. And what this shows is a tremendous change between 2000 and 2015. So the annual number of average admissions for an internal medicine resident in 2000 was 2,700, and it's now 4,500 or more, almost doubled. The CCI refers to the Carlson Complexity Index. The higher the score, the more complex the patients. The average patients in 2000 were 0.83, again, almost 4 times as high in 2015. And we know the complexity of our patients over the past 8 years has only increased. Some of these other numbers astound me. The number of medical problems our patients had in 2000 were roughly 2, up to 20 now, 10 times the number. Number of medications, 13, now closer to 17. And this number I find very surprising. The discharge summaries, maybe they had 1 that would have to review, now closer to 5 or a little more than 5. And maybe I had to review a thick chart with 43 notes, but in the EHR, there are an average of 1,200 notes on any patient of complexity. So none of us did this during our residency. And in addition, our house staff deal with time compression, duty hours. And so they're doing more work in less time and experiencing a level of stress that I didn't experience. And so I think when we look at these arguments, we can say, well, is that really the best way to defend not taking care of ourselves? And the other thing that I should say is that the foundation or the assumption underlying at least these first 3 arguments is that when I do put my patients first, they do better. And much of the rest of our talk is around the idea that our patients don't do better when we put them first. That part of our ethical obligation to take care of ourselves is to cause no harm. And so we are in a changing clinician culture where the message now is I need to take care of myself in order to take care of others. And again, much of the rest of the talk is going to focus on where that comes from. So if I were to say to you, we have a system problem. We have a problem that compromises patient safety, increases the cost of care, decreases patient satisfaction and our ability to communicate clearly with patients, jeopardizes the accreditation of our programs. I would imagine someone would say, that is huge. We better fix that problem. And I would say we'd have an ethical obligation to address these things, particularly as it related to causing patient harm and limiting access. And we do have that problem. We have that problem, and it's called burnout or clinician distress. And I'm going to first talk about the extent of that problem and then talk about its consequences for patient care. I'm sure that all of you see these headlines, but just so you know, across the lay press, we have US News and World Report and the New York Times here, across medical press, across the World Health Organization, the Institute for Healthcare Improvement, everyone is talking about the crisis in clinician well-being and our failure to care for our clinicians, particularly those who put their lives on the line during COVID. But the problem existed before COVID as well. The first studies that looked at this were done by Shanafelt and his colleagues, originally at Mayo Clinic, now at Stanford. And what you're looking at here are graphs in burnout and graphs in work-life integration. This first is a graph in burnout. And what it says is a randomly picked general population burnout from 2011 to 2014 to 2017 to 2020 stayed pretty much the same in the general population. But when we looked at physicians, and this was not all clinicians, this was specifically physicians, we saw a huge rise in burnout between 2011 and 2014. It started to come down in 2017 and came down further in 2020, and there was room for hope. This is where a lot of the wellness interventions started, and the hope was, wow, maybe we're hitting some trends. Similarly, work-life integration, where higher is better, the general population stayed pretty stable. Physicians decreased initially, and then we started to see a positive trend. But then guess what happened? COVID. And that was the fear of, the virus, everything you see listed here, everything that many of you could list, that really contributed to both burnout and moral distress in clinicians. And so we see the same graphs in a study that was done in 21 to 22, and suddenly you see a big change. Burnout jumps precipitously. Work-life balance decreases. Work-life integration is the term they use, precipitously. And this data has been supported by a second study that was done more recently, but still during the pandemic, that looked at in late 21, what the levels of burnout was and what the intent to leave work was. There were unprecedented levels of burnout, greater than 60%. Previously, it had hovered around 45%, also unacceptable, but a very dramatic increase with the pandemic, an intent to leave the job. And it says perhaps due to a combination of depletion, exhaustion, and the sense of not feeling valued. And we'll see in a slide or two how the intent to leave correlates with clinicians actually leaving the workforce. Moral distress is a term that some people prefer to burnout. I think it's different than burnout. Burnout is a syndrome of emotional exhaustion, cynicism, and depersonalization that is related to work and has been more extensively studied in caring groups. In groups of people who care for others than moral distress. Moral distress is a term that came from the Vietnam War, and it occurs when professionals can't carry out what they believe to be ethically appropriate because of internal or external constraints. It also might be when they carry out something that they believe to not be appropriate because of the same constraints. In 2018, Slate, popular journal, published an article about clinicians experiencing moral distress. And that term has really taken off to capture a lot of the loss of a sense of integrity, the questioning of one's own values, the questioning of one's own moral judgment and isolation and feeling devalued that many clinicians experienced during the COVID pandemic. And in that previous study I cited, one of the things that correlated the people who were most burnt out were those that felt least valued by their organizations. And there were lots of causes of moral distress from COVID-19. And this slide, I believe I got from Dr. Geppert when she presented on moral distress one time, so I want to be sure to give her credit. In terms of practicing outside of the scope of practice, I did my first inpatient month in 16 years. It was scary. And I am sure other hospitalists would have done a better job, but I was better than nobody, and our hospitalists were swamped. And so that sense of, being at the envelope of my comfort level, or I'm not getting the right metaphor, but being right at that border where I feel comfortable is really significant. Scarce resources, concerns about bringing the virus home to others, concerns about having limited access to PPE and limited access to life-saving equipment. All of these were sources of moral distress. And so I think based on what I presented, there's plenty of more literature I'm happy to share, but we have a crisis of burnout and moral distress. We're looking at 60% of our clinicians, sometimes higher, experiencing this distress. And this is what leads to the ethical imperative to change our culture from that self-care is selfish play. Because we have a system problem, as I mentioned, that impacts all of these areas. Let's look at quality and safety. We know from numerous studies now, looking at both physicians and nurses, I am not familiar, and APPs, I'm not familiar with studies in respiratory techs or some other clinicians, although they may be there, showing that when you have a physician who's burned out, surgical errors increase, medication errors increase, the rate of infections increases. There was an interesting study, I'm not sure this is the reference I have on here, that looked at ICU patients and looked on their team. And the higher the burnout, it specifically looked at nurses, the higher the burnout of the nurse on the team, the higher the rate of infection in the MICU patients. Now, I'm sure there were confounding variables. I'm sure it wasn't an ideal study, but we see it time and time again that patient outcomes are not as good when they are cared for by physicians who are under distress. We also know that when we're under distress, we order more referrals and diagnostic tests. And that seems pretty intuitive to me, by which I mean, if I am feeling very, very rushed and very pressured, and I have patients in the waiting room, and I feel like I'm being pulled in 1,000 directions, and a patient comes in with low back pain that I know doesn't need an MRI, but they really want an MRI, I am much more likely when I'm feeling well, when I'm feeling less stressed, when I'm under less distress, to have a really engaged conversation with the patient about why an MRI might not be needed. But when I'm under the gun, I'll probably order that MRI. And so you can see how this multiplied increases the number of referrals and diagnostic tests and the cost of care. Similarly, patient satisfaction decreases, complaints increase, malpractice suits increase. Physicians who are under distress are less professional. And in fact, and that's true for all clinicians, what we're seeing when I'm on my wellness listservs now, looking at faculty well-being, medical student and resident well-being, there's a lot of chatter about an increase in unprofessional behavior that we're seeing after the pandemic as people are trying to cope with their experiences. How is patient access impeded? Well, this gets to the idea of intent to leave. In physicians, burnout's associated with a 200% increased odds, or twice the rate of intent to leave the current practice for reasons other than retirement. And in nurses, again, burnout and job satisfaction is associated with leaving and often translates into actually leaving. And this was an alarming study published at the end of the year, noting that approximately 1 in 3 physicians, APPs, and nurses surveyed intend to reduce work hours. And 1 in 5 physicians and 2 in 5 nurses intend to leave their practice altogether. And I don't need to tell you that in a state like New Mexico, where we're already facing a shortage of access to healthcare, that this is a huge reason to address clinician well-being. We know again that the number of RNs decreased. It was the largest single drop ever observed between 20 and 21, again, during the pandemic. And the likely factors were pandemic burnout and frustration. Oops, I'm sorry, I hit something earlier than I wanted to hit. And so if we want to improve patient access, we need to address the issue of clinician well-being. If we are burned out and not doing well, our accreditation is jeopardized, not only because of access being impeded, because of quality of care going down, quality of communications decreasing, patient satisfaction, but because the ACGME, which is our accrediting body for all of our residency and fellowship programs, requires us to have a well-being program to address clinician well-being. And they very cleverly required us not only to address house staff well-being, but also faculty well-being as well. So that both the requirements are part of the Common Core requirements of a residency program. And if those requirements aren't met, our accreditation is jeopardized. Similarly, the LCME, it's slightly less stringent, but that is the licensing body for the School of Medicine, has a requirement for well-being program. If we lose accreditation for our School of Medicine and for our training programs, that impacts many of our programs, and our certification as a stroke center or a trauma center. We need those programs. And so there's significant repercussions to not addressing clinician well-being. I'll also say that some hospitals are now using physician well-being as an indicator of quality. That hasn't caught on it hasn't caught on widely yet, but I believe that it will in the coming years. Okay, we already talked about how when we have distressed clinicians, the cost of healthcare goes up because of unnecessary ordering of tests and referrals. But there's also the cost of turnover for RNs, for MDs, again, for more referrals and more tests. And of course, the cost of medical errors, malpractice claims, absenteeism, and lower job productivity. So all sorts of ways that the cost of healthcare can increase as a result of this. And so just to summarize, before I summarize, just want to point out that the estimate from a paper that was published in 2020, $4.6 billion a year is the estimated cost attributable to burnout in the US. And we can think of all the ways that we could use those dollars better. And just to summarize, this is the impact of unwellness. It impacts the individual provider, increased risks for divorce, car accidents, substance use, depression, suicidal ideation. It impacts the quality of care our healthcare organizations deliver. And of course, most importantly, both of those impact our patients. And so I would argue that we have this system problem that compromises patient safety and the other domains that you see here, and that we have an ethical imperative to provide care of the highest quality, to minimize harm, to improve access and minimize cost, to enhance communication and provide informed consent. And none of these things happen when we have distressed clinicians. And so to me, there really is an ethical imperative to see that our physicians are feeling well, our clinicians are feeling balanced. And I should say that when we use the term well-being in the setting of professional well-being, I'm not talking about underlying medical issues. You can have medical issues and still be well at work. I'm referring specifically to your quality of life at work and how your quality of life at work impacts what you do outside of work, and how there are ways that we can support that. So I do think culture is changing. I do think there's a reason. There were ethical reasons or ethical arguments for this initial belief that we should sacrifice ourselves for our patients. And now we see the imperative to move away from that, because sacrificing ourselves for our patients does not lead to better care, better access, more satisfied patients. And so we're going to talk about how culture is changing. And how do we change culture? Well, we first define or articulate what we want the culture to be. That's the first step. Where are we going? What do we want that to look like? And one way that has been interpreted in the field of well-being is with the idea of a quadruple aim. The triple aim of healthcare, introduced by Don Berwick, was to improve patient health, improve population health, and lower the cost of healthcare. Then came the idea of the quadruple aim. This article is about 10 years old now, not quite, that said, in order to do that, we really need to take care of clinician well-being as well. And I was in a lecture yesterday by Chris Sinski, one of the leaders in this field. I don't know if anyone else in the audience was there, but she summarized this quadruple aim, I thought, in a beautiful way. And what she said is, we are aiming, this is the ideal future we want. This is how we're going to change our culture, the goal we're working towards. We want care better than we've ever seen, health better than we've ever known, cost we can all afford, delivered by professionals who find joy in their work as they commit to serve others. That's what this is all about. It's finding a good quality of life in serving others and delivering the highest quality of care. So the good news is most of our professional, I should say all of our professional societies, our leading bodies for healthcare, are all over the issue of clinician burnout, clinician distress, clinician unwellness. The National Academy of Medicine in the fall of this year released a national plan for healthcare workforce well-being. The Surgeon General issued an advisory addressing health worker burnout. The Institute for Healthcare Improvement has a whole framework. And the AMA is really working to reduce physician burnout. And in other talks, I spend the whole time talking about these initiatives. I won't do that now, except to say that they really focus not on whether individuals are doing yoga or practicing mindfulness. That's not what professional well-being is about. Those are important. You need to take care of yourself, but it's more in what is the system in which you work doing to make practice easier and more efficient? And what are they doing to create a culture in which there's psychological safety, where you are able to access mental health care if you need it, where there's not a stigma attached to that, where you feel supported by your peers, supported by your leaders. Those are the kind of changes that we're looking at. And I will say that UNM has been recognized through the work of my colleagues and myself, the Office of Professional Well-Being, as being on the path to getting there. We're at the very beginning. We're all at the beginning across the country, but we are making systems changes, like having a peer support program in conjunction with UNM hospital well-being, employee well-being, and other systems changes, trying to make the EHR easier to use by surveying and getting a sense of how folks are feeling. So we are making some progress here. And I think that's important to note because as someone on the front line, I was in clinic this morning, I can feel discouraged. It doesn't always feel like we're making progress. It's a hard system to practice in. But I believe we are, and I believe we have an ethical imperative to continue that progress. And so with that, I'm going to conclude that burnout, distress, and exhaustion are at record levels in the medical profession, and it's threatening our very ability to provide high quality, cost-conscious care. If we don't address that fourth domain of the clinician wellness, not just the triple aim, but the fourth aim, we're going to have a problem. And so there is an ethical imperative to address the system and to make these kind of changes. And there are really a lot of evidence-based strategies and tools that we've been using at UNM and using elsewhere across the country to make a difference. And just like quality involves all of us, practicing ethically involves all of us, creating an environment in which we all can be well is not just the work of one office or one wellness person. It's really the work that all of us have to create the kind of culture and efficiencies of practice that can sustain us. And so with that, I will open it up to questions. I wanted to leave a good amount of time for questions and discussions, and I look forward to that.
Liz, thank you very much. That was a compelling argument, and please, if you have questions or observations for Liz, please feel free to wave or put up your hand or just talk out loud.
I got a question in the chat about sharing my slides. I'm more than happy to share my slides. And I don't know the best way to do that, but I'll share it with the person who asked me to be sure.
As if you wanted to send them to me or to Ramona, we can send them out to the list.
Okay, that would be great. I'll certainly do that.
I have a question that's, you made a compelling argument as to why we as clinicians need to change our attitude about what is good and right to do as practitioners. And yet we're in an environment that is increasingly industrialized and capitalized, and private equity firms are moving into various branches of medicine to really wring out any profit possible. Do you have arguments? I mean, and a lot of the arguments that you made should be compelling to our administrators and our leaders, but do you have a sense that we're gaining against the message that the job is to be more and more productive and produce more widgets or more RVUs? Do we have a response to this?
I think we do. There are several responses, and one is to recognize that medicine is fundamentally a practice between people. It's based on relationships. And Dr. Sinskey, again, who's a national leader in this area, gave a great talk about that yesterday at our Resilience Echo. And, if a patient comes in, this is an example that she used, and actually it came up in clinic today. There was a patient who's assigned to a different primary care provider, was put into my clinic today for a hospital discharge follow-up. I'm going to see that patient. I'm going to temporize because in a 25-minute visit, I can't review the whole social history, the whole past medical history, everything. I'm going to do what I can. And that patient's going to have to come back in a week to see their primary care provider because we're not interchangeable, right? So seeing someone you have a relationship with makes a huge difference. And I think that as we have ongoing issues with access, ongoing issues with quality and safety, the system will change. I believe it has to. The model I have is sort of a ball balanced on a mountain. And I think the forces to change, including the corporatization and all that, is the forces are there with newer and newer data showing that we're really harming the healthcare professions, harming our institutes, costing more than we would otherwise. So I'm sorry, I didn't answer that directly. Yes, I think the momentum is there. I think it's based on the same arguments, and I think it'll take time. And some places are way ahead of us, namely Canada. But that is not a surprise. I do see a couple of questions in the chat. One is, how do we encourage medical students to practice well-being? Great question. I spend a lot of time on that. And I also see one of the answers in the chat, which is that we need to role model for our medical students. And we need to role model for everybody, frankly. So when I respond to an email, and well, I'll out Jonathan with myself. Jonathan and I were emailing last night about 8 p.m. When I email him, I'm sending the message that I expect someone to be on email at 8 p.m. And when he responds, he's sending me the message that, yeah, it's nothing unusual about being on email at 8 p.m. We as leaders should try to limit the amount of time that we're on email after hours, be clear about our expectations for others, including our students. And there is no better way than role modeling that. And we do a lot of the role modeling for our students. For example, next week, we have a panel of physicians in recovery coming to speak to our students about their experiences with substance abuse and how they recovered and how that's impacted their career and what they've learned as a result of those experiences. This is the 6th or 7th year we've done a talk like that, and you can really hear a pin drop. It's very inspiring for the students. We have panels of students and leaders who share their mental health stories. And I think the way we're going to destigmatize help seeking and mental health diagnoses in our profession is by talking about our personal experiences and by sharing them. I have one more thought about the medical students. I'm sorry, but when we require biochemistry, when we require anatomy, we're sending a message that we feel that the knowledge gained in those classes is important for your practice. I think some of our well-being classes, which we can frame as professional development around issues such as boundary setting, limit setting, self-care, should also be required to show that the institution values these as much as anatomy, that we as an institution believe these are skills that you need to have, whether it's communication skills or being part of a team. These are skills that you need to thrive in your medical practice. And I don't think we always send that message. I see another question. When we lack sufficient staffing, how do we ethically address the balance between a healthy workload versus our community needs? Terrific question. There's no black and white answer. Right now, I believe we have nurses at 2 institutions, not in the state, who are on strike for this very reason. And maybe someone knows more about the nurses' strike than I do. And they're on strike not because they don't want to care for patients, but because it's unsafe in their current environment to care for patients. And so they're making a short-term sacrifice for longer-term improvement. Now, let me be clear. I don't want anyone leaving here and saying, Liz just advocated to go on strike. We're all going to go on strike now. No, that's not what I'm saying. But I'm saying that sometimes ethically, we can't give care that's not safe, that we know it's going to harm patients. I mean, I often ask, if I'm doing this talk in person, how many of you have come to work when you've been sick? Right? I can see most of the hands going up, at least those that are showing their hands. And, I know I'm not giving my best care. And I know I'm risking exposing my teammates. And, is that really the ethically right thing to do? So I don't have an answer to your great question, Sabrina, but I think it's sometimes the forces are going to push us one way or another. And I'd be curious to know if anyone else has thoughts on Sabrina's question.
Dr. Lawrence, thank you for that amazing talk. And it was so on point in the sense that typically when we hear talks about wellness and physician wellness and staff wellness, it's typically all the onus is on the individual, about mindfulness and meditation and all these tools that we can use to combat the stress of the environment. But the bottom line is the environment always wins. And the only way to change any of this is to change the environment. And that is what you focused on. And my hope is that with enough discussion and enough push, we can actually make changes. In terms of the question about staffing shortages, you need redundancy in the system, and the system leadership needs to just step up and say, we need to hire more people because what we're doing, clearly isn't working. And it is not a matter of efficiency. Efficiency makes you more efficient, which means you just do more work in the same amount of time. And it's a matter of doing less. and focusing on what's important. So anyway, this talk was so on point, and so timely. And I do think that change is possible. And when you look back over 100 years at the changes that have occurred in this country and around the world, obviously change is possible, but we need enough people to come together and make a decision that we're going to change, and we're not going to continue to do things the way we always have. So anyway, thank you.
You're very welcome, and thank you for those kind words. The focus has to be on the system. I do think that the well-being movement got off on the wrong foot talking about all the tools that you mentioned. It really is the systems in which we practice, the culture in which we practice, and all of the professional societies I cited, the National Academy of Medicine report, the Surgeon General's report, all focus on the systems. And I do think that message hopefully is getting through. And I agree. One reason that people come into work when they're sick, and I certainly have been guilty of this, I don't want to dump on my colleagues, right? I don't want Jonathan to have to cover for me because I know he's as distressed as I am. So I'm going to come in. But if there were afloat, if there were someone else, if there was another body who could do the work without that sense of being dumped on, without that sense of their being overloaded too, I think we would take better care of ourselves. And Mark Linzer, who's again one of the leaders in the field at Hennepin County, years ago proposed overstaffing different departments so that there was always a float person for those unexpected times when a woman of childbearing age gets pregnant and takes maternity leave, or when someone has to care for an older parent, or when someone is sick. And it will pay for itself in terms of recruitment and retention. So I see a question about why don't we have childcare on site or healthy food to eat? And those are both terrific suggestions. Those are suggestions that are right in alignment with the idea of creating a culture of wellness. I will say, thanks to work of many in leadership and because of the issues that came up during the pandemic, we have bought, UNM has purchased, HSC has purchased property to build a childcare site. It's a couple of years off, but I think senior leadership certainly recognizes the importance of providing childcare in order to have people come to work and feel at peace and able to focus on work. So my office is on the task force that is related to that. It'll be a couple of years in coming, but I think we're getting there. And healthy food is a great point, and anyone who wants to work on a project around that, Dr. Sauer, who is a psychiatrist who works in my office, is starting a project around trying to look at the food that's in the cafeteria and the issues involved with that. The other thing we're doing for our residents is trying to stock the refrigerators in call rooms with healthier food. That doesn't help everyone on this call. It helps our house staff, but they're the ones who are often in the middle of the night, eating the donuts that are left at the nurse's station. So hopefully we get that message.
Any other comments or questions?
I have a question.
Please. Hello, Dr. Clue.
Thank you very much. Very, very thought-provoking presentation. Well done. I wonder what has been the impact of the decline in well-being and the increase in stress on the research publications, the scholarly work by residents and attendings, especially in the last 2 to 3 year COVID period?
That is a terrific question, and you in fact may have an answer more than I do. I don't know the answer to that. I can only imagine that with the focus on clinical care and what everyone was doing to take care of a hospital that was at 140% capacity and clinics that were similarly full, that both medical education and scholarly work decreased. I know that in the literature, I have seen articles about the change in the shift to service away from education that many residents have experienced during the COVID pandemic. I have to believe it's the same with research, but I don't have any data to support that. I'd be happy to look, and if I can find something, happy to get it to you.
Thank you.
Well,
Is there any, oh, sorry.
no, please go ahead.
Is there any evidence that different types of organizations do better or worse? In other words, for-profit, a quasi not-for-profit, and a full not-for-profit. Is there any evidence that outcomes are different in terms of moral distress or burnout?
So there is difference from individual to individual organizations, of course, but I haven't seen any clear trends between types of organizations. In the Shanafelt papers, who's the one that leads the triennial studies looking at burnout, they do look at, if you look at the supplementary material, academic institutions versus private institutions. They look at the VA. I don't know if they've compared profit for nonprofit. They may have, and I'm not familiar with it, but there hasn't been any significant differences that they've seen. So there may be some newer research I'm not familiar with, but to my knowledge, there's no difference, and that's a great question. So one simple wellness intervention I've been advocating for a couple of years now, and each of you can do it, is to have 50-minute meetings instead of 60-minute meetings back to back. So that people have a chance to have a bio break between meetings or take a sip of water or stretch. So I know we're done a few minutes early. That was not unintentional. I'm happy to stay on the call to 1. But for those of you who want to take a little break before your 1 o'clock meetings, please do so. And please consider passing on those 10 minutes. Thank you very much. I appreciate how engaged everyone was.
Thank you,
Thank you.
Dr. Lawrence. And we'll walk